with the slant of talking about it, how it affects older patients. So let's see if I can get the slides to move. There we go. So the objectives, so what I'd hope you take away from this is just be able to explain the impact anxiety may have on our older patients, identify meds and conditions that contribute to anxiety, discuss treatments for anxiety, and apply information to Joe's patient's case. So the impact of anxiety in older patients after I um, heard all your specialties. I'm sure you are very aware of all these, but cognitive decline, depression, increased risk of medical illness, increased utilization of service, increased physical disability, and really decreased quality of life. So all of those are things that can occur, and I often do see occur. But in addition to those types of things, I also do see in our older patient, this is a diagram I made a while back, but really kind of shows the way that pain, anxiety, depression, insomnia, and decreased mobility in our older population are often interrelated. They all lead to functional decline of our older patient, and oftentimes it's really hard to tell which one came first. So, what was the starting point with all of this? And sometimes it's more than one that may have occurred. So, one of the things that I noticed is that really references do state that anxiety is somewhat rare in our older patients, not occurring in about 5% of patients is what I had read. But I really do feel that I see this very frequently in both our inpatient and outpatient practice. So it may just be the type of patients we're seeing, but it seems to occur quite a bit. I know some authors have suggested that anxiety disorders are often under-recognized in our older adults in the community setting. Possible causes is that perhaps believing those symptoms are just parts of normal aging. The patients may be minimizing their symptoms due to the stigma of having that type of a diagnosis, or just not remembering, especially with our patients with cognition issues. And then there are also, it sometimes appears as more atypical symptoms in late life, things like hoarding, fear of falling, and dizziness. All right, so some common medical conditions to contributing to anxiety, and there are many other medical conditions that I would say are less common. But depression, insomnia, pain, as I already talked about, angina, arrhythmia, CHF, asthma, COPD, hyperthyroidism, and hypoglycemia are all reported to be contributors to anxiety. And this is an area that Joe and I interact with quite a bit. We're always looking for those medication contributors to whatever the symptom that the patient is having. And there are quite a few that can contribute to anxiety. Albuterol, we really would think about our patients that have COPD or asthma. And if they're using their albuterol inhaler quite a bit, then we would like to really look at what else they're doing for those diagnoses and making sure that we've optimized therapy so they don't have to use that as much. Because certainly it can cause anxiety as well as some other things as well. Theophylline we don't use too much anymore. Corticosteroids can cause a variety of issues, including anxiety. Those psychostimulants, of course, can contribute to anxiety. Pseudoephedrine, an OTC medication, can contribute to anxiety. Levothyroxine, if the dose is not correct. Caffeine, if they're using a lot of it. Montelukast is one of the newer ones that have been added to this list that we do know there's an association with a variety of disorders, including anxiety. And then some of the antidepressants, fluoxetine tends to be more activating, venlafaxine, especially at initiation, and bupropion. So our non-pharmacological treatment for general anxiety disorder, when we talk about older adults, that there is some controversy about whether cognitive behavior therapy relaxation is still effective. But the studies have shown, yes, this is still effective. It is certainly more effective in our patients that are more cognitively intact than those that start to have some issues in that area. some studies indicate that relaxation therapy is more effective. But we do see, and this is something that we see in our practice all the time, is getting patients, our older patients especially, out to go see a provider tends to be a big area, especially with frequent visits, tends to be an area where patients have trouble doing that. So if there's one thing you could say good about COVID, which this is, it's not many good things we can say, but one thing that it did do was that it did help more availability of telehealth visits, since those are now reimbursable. And many of our patients do utilize that. So pharmacological treatment of anxiety disorder. So medications that treat general anxiety disorder, there aren't really that many. There's been a couple that are newer to what we can use, but SSRIs, SNRIs, and these are not all on label to use, but some are off label. All of them have some evidence, or just about all of them. Buspirone. And then pregabalin is one of those newer medications. It is off-label, of course, has not gotten the indication, but quite a bit of evidence for using those. When we are treating insomnia in older patients, these are the three that we normally would use. There are some others, but we are always looking at risks and benefits, so risks of the side effects and then the benefits of therapy. So benzodiazepines, tricyclic antidepressants, hydroxyzine, quetiapine, all of those do have some evidence for use as well. Quetiapine is one that actually I had not seen before preparing for this presentation. So it has issues with many of our older patients. So antipsychotics, of course, have that black box warning of increased mortality in our older patients with dementia. So I'm not going to really talk about that today. It's something that is interesting that it was included in some of the review articles. All right, so SSRIs and SNRIs, when we think about the advantages of those drugs, SSRIs treat both anxiety and depression. SNRIs also add pain. So that is definitely a benefit of using an SNRI in many of our older patients that are dealing with chronic pain as well. Onset 2 to 4 weeks or longer, as I'm sure all of you know. They do have an increased risk of falls. I know when this was first reported, it's probably been 15 years ago now. I didn't want to believe it, but it does seem that yes, it is not necessarily dependent on which SSRI or SNRI you use, but there is an increased risk of falls. We see an increased risk for hyponatremia and SIADH. Both of those are higher in older patients. We can see the GI bleeding disorders. Discontinuation syndrome is especially important in our older patients who are not adherent all the time to their medications. Sexual dysfunction is one that we might forget about in our older patients, but I know that I certainly have been involved in cases where this was a big issue for the patient. When looking at the specific agents, paroxetine and fluoxetine are not really recommended in older patients, mainly because it has some anticholinergic effects, and fluoxetine has such a long half-life that it oftentimes accumulates in our older patients. And so we would have to watch for that. Usually causes the insomnia because of that long half-life as well. Citalopram and S-citalopram are known QTc prolongers, so we would try to avoid those in our older patients. They have, citalopram in particular has that FDA warning that says the maximum dose you can use is 20 milligrams per day in a patient over the age of 65. Withdrawal occurs quickly with paroxetine and venlafaxine, so tying back to those patients that may miss medications, we would want not to use those in those particular populations as well. All right, buspirone is the next medication that we would commonly use in our older patients. Oftentimes, we are using it as an add-on to an SSRI or an SNRI. It is thought to have less dependency, but you still do need to wean it off. I think that's more so in our older adults than in our younger patients. The onset is 2 to 4 weeks or longer. I've seen buspirone used as a PRN, and I would not expect it to work on a PRN basis because of the fact that its onset is so long. And the response rate has been reported to be a bit inconsistent. In particular, there are studies that say that it tends to be less effective in patients that have previously been on benzodiazepines. And that would make sense since it doesn't really work as needed medication and certainly doesn't work as fast as a benzo does. Pregabalin, advantages of pregabalin is it does have a fast onset, so you can use this as needed and see some effect. It may help with pain as well. The limitations in older adults is dependence. So if we were going to stop this, we would definitely need to wean it. And along with just the physical dependence, there have been some reports that of more addiction type of behaviors going on with pregabalin as well. So again, we need to choose our patients carefully on who we're going to use this on. Sedation, decreased cognition can occur and have been reported to occur, just like when we use this for pain. That tends to be something that is more likely to occur if you don't slowly wean this up. So we normally start with pretty low doses in our older population and then slowly wean it up, and don't normally see too much sedation when we do it that way. And then respiratory depression is a brand new warning on this medication. So we'll talk about that in just a minute. I did want to include the study because this is a drug that we use and it is a non-approved use, that there is a systemic review and meta-analysis that did use this medication. Quite a few of randomized controlled trials that have been out for quite a while about pregabalin for the use of general anxiety disorders. So this particular trial was the systemic review and meta-analysis of these studies. They used Hamilton Anxiety Rating Scale as the efficacy rating, and safety ratings was the dropout rates. They looked at pregabalin versus placebo. In this part of the study, they looked at their full age range, which is still 35 to 72 years old, so not really getting into our older patients. But they did find significant improvement in HAM-A with pregabalin use versus placebo. No difference in dropout rates in pregabalin versus placebo. Now, the next part of this was in the younger population that they had in the study, that they looked at no significant difference in HAM-A with pregabalin use versus benzodiazepine. Again, and the dropout rates were lower in the pregabalin group compared to the benzo group. So a couple things that have been reported since that meta-analysis is there's 33 patients. This was a study that was only 33 patients. They received pregabalin and cognitive behavior unit. It did include those older patients as well. And our patients that got the pregabalin actually had a significant lower benzodiazepine use. That new warning on pregabalin, I did want to get into just a little bit. It is basically stating that this medication can have respiratory depression in those with respiratory disease, on other respiratory depressants, and in older patients. So another thing for us to be aware of if we decide to go with the pregabalin. Now, I don't know how many of you are using pregabalin for anxiety. I know in our older patients, we often find lower doses, because we start with lower doses, that lower doses are effective, lower than what has been reported in the literature. So generally, we would start with 25 milligrams at bedtime to see how they handle that, and then go up to Q12 hours, Q8 hours, and upward from there. So we do a fairly slow titration when we use it. Hydroxyzine has a rapid onset. There is limitations in older adults that it has anticholinergic effects. And remember, those would contribute to falls, contribute to cognitive defects deficits, including delirium, would also contribute to constipation and urinary retention, which are problems in many of our older patients already. So in general, we try not to use this medication, similar to what we did with looking at pregabalin, also looking at what the literature tells us about hydroxyzine. This was a Cochrane review that was done that had 5 studies that they reviewed with 884 participants. They did find hydroxyzine to be more effective than placebo. Tolerability was no difference compared to placebo. Efficacy, they did look at hydroxyzine versus chlorodiazepine epoxide. A lot of these studies were very old, and they found no significant difference versus buspirone. Again, no significant difference. But the hydroxyzine, as we would expect, was associated with a higher rate of sleepiness and drowsiness. I think an important thing that this Cochrane review also stated was there was no recommendations in older patients that could be made. And that is because looking at the different studies, and you can see those studies were old, that were included in this Cochrane review, is we did not really have patients included that were over the age of 65. Now, looking at the data from any other studies that have recently been done, and I'm surprised there haven't been more studies done because we are using, I see this used quite a bit, but the other study that was a double-blind randomized controlled trial, there's only one when I did a search, and that only also included patients up to 65. So we don't really have data showing us that it is okay to use this in patients that are over the age of 65. And I know I do see patients having trouble with hydroxyzine, especially with the cognition issues that can occur in falls. All right, so moving on to those drugs that we don't use too often, benzodiazepines, of course, have a great onset of action. They work very quickly, effective for many of our patients. Limitation, again, is falls, delirium. They can have that paradoxical effect. So sometimes when we're using it, especially if it's being used to treat delirium, patients will get more excited rather than calming down. It can cause functional decline, and we also know that it causes, of course, dependence and addiction as well. So the withdrawal symptoms can be very severe, can actually get to the point of being life-threatening due to the seizures that it can cause. And weaning is challenging. So there are studies out that have specifically looked at benzodiazepine weaning, and the method that is being recommended these days by several different sources is decreasing the dose by 25% every 2 weeks until you get to the 50% mark. And then at that point, you may need to decrease a little bit slower. Tricyclic antidepressants, efficacy is an advantage, has lots of limitations in older adults: cardiac toxicity, anticholinergic effects, orthostasis, seizure risk, dependence. I rarely see, and of course, and again, we do need to wean tricyclic antidepressants as well. I rarely see this actually being used for anything other than very small doses that are used for, usually for insomnia, but they, especially the amitriptyline, which is the most common one that is used, has a very high anticholinergic effect. So we try to avoid this in our older patients. All right, so that was just a fast and brief overview of these medications that in some of the issues to think about with older patients. So in summary, I would say that to watch for anxiety that's not been treated in older patients. SSRIs are really the preferred for long-term treatment of anxiety, although in our older population, that's according to guidelines, our older population, I would say that many references suggest SNRIs are also a preferred agent. And many anxiety medications have multiple risks for our older patients, so monitoring is really essential with these types of medications. I am now going to turn this over to Joe, who's going to present the case.